Right, fine. Where were we, children? I spoke about anticoagulation, right? About mechanical heart valves. Yeah, right. Okay. So remember, what is this? You need to know about if if reversal is needed. If there's a patient who is delivering with full anticoagulation, if the patient is on heparin, we give what? Protamine sulfate, right? Then if the patient is on warfarin, then we have to go, of course, we have to give vitamin K plus prothrombinase complex, right? Those are the two things that we need to know. But this, of course, we will do that in conjunction with the hematologist if necessary. Okay. So those are things that you just need to know out of, just for your general knowledge. Then how is heparin? So that is what you have to know about the general. Next one. So that's mechanical heart valves, which you no need to know about, right? The second thing is we need to talk about pulmonary hypertension, right? This is one of the biggest problems which we get. Normally, when a patient has pulmonary hypertension, if the patient comes to us to the infertility clinic, children, and then with a diagnosis of pulmonary hypertension, then what do? We will, before getting pregnant, we will refer them to the cardiologist. The cardiologist will do a echocardiogram, assess the patient completely, and then they will give a recommendation, right, as to what to do. And usually, if there is very severe pulmonary hypertension, right, and that definitely is going to get worse during pregnancy, they will tell the patient not to get pregnant. Okay, so they will either ask the obstetricians and the gynecologist to do give a very good contraceptive method, right? And therefore we will go with that. It should, most of the time they should not be they should not be told that to do a permanent method, because at some point in time there is a possibility for pulmonary hypertension, they might get a heart-lung transplant or a lung transplant, right? In that case, the patient should be able to go ahead with the pregnancy. Okay, so therefore we will give them some form of good contraception to wait until the problem is hopefully resolved, right? Secondly, if the patient has severe pulmonary hypertension, sometimes the cardiologist will recommend termination. They will say, look, if this pregnancy continues, this woman is going to die. So at that point, legally, termination is allowed in Sri Lanka. So it has been in conjunction with the psychiatrist. Psychiatrist needs to get involved about the person's mental status. Then the cardiologist, then two consultants, obstetricians, all these will get together and decide whether termination, whether the termination is necessary to save the woman's life. However, the woman has the right to refuse, in which case, if she refuses, look, I don't want termination, then of course she will carry her pregnancy. Then we will have to manage her with a multidisciplinary team. As often it happens in Sri Lanka, what happens is, I have met so many cases, unfortunately, where the woman who has pulmonary hypertension, right, with even reversal of Eisenmenger's, right, reversal of shunts and all, they have a severe pulmonary hypertension. They will attempt for a pregnancy without even the spouse knowing about it, right? So usually they would have attended clinics, they would have been advised against pregnancy, they would have said, okay, use, but they do not do that. Because due to all the social factors and the pressures upon these women. So the spouse sometimes, if it is, unfortunately, there are arranged marriages, so sometimes the spouse does not even know that the woman has heart disease, right? And then they become pregnant and they come to us, but they come to us late. Because some of them will know that termination is going to be offered, right, and advised. So they come around 20 weeks, 24 weeks, right? So where sometimes termination is not possible, right? And therefore, we have no other option but to manage the pregnancy. And what happens is when they decompensate, then anyway we have to go for delivery, like a hysterectomy or removal of the baby, right? When the woman may be very much compromised, we might need to do that, right? Now, if you look at pulmonary hypertension, the whole problem is what? There is blood pressure, there is hypertension or in the pulmonary capillary system or in the pulmonary system, there is increase in pressure, right? Usually these are due to 4 problems which we know of. Number 1 is, most common is idiopathic pulmonary hypertension. We really do not know the reason for it, but there's idiopathic pulmonary hypertension, right? That is number 1. The second one is Eisenmenger's. You all know what Eisenmenger's is, right? Initially, there's a shunt from left to right because, of course, in the left side of the heart, the pressures are higher. So the blood comes onto the right side, then goes to the pulmonary circulation and drops back onto the left side of the heart because there is a VSD or sometimes ASD. What happens is because the left side, the pressures are higher, the blood shunts from left to the right. Okay, so they continue. But at some point, what happens is when the pulmonary hypertension builds, at some point, the right-sided pressures are higher than the left side. So what happens is the blood is not pushed through the pulmonary circulation. It just goes from the right side of the heart to the left side of the heart. So since it's not going through the pulmonary circulation, it's non-oxygenated blood. Okay, and then non-oxygenated blood is pumped out from the left side, so it's hypoxic. So they can go into all sorts of problems, right? So that is Eisenmenger's. The third kind of problem is when there is acquired problems like connective tissue disorders, which might cause thromboembolism of the pulmonary system. So you have chronic thromboembolic disease, okay, with different types of thromboembolism happening in the pulmonary circulation, and that causes pulmonary hypertension. Most often quoted ones are what? 2 things: connective tissue disorders, what is this? Scleroderma, and then of course sickle cell disease also can cause this problem, right? So these are the 2 things that you need to be aware of, and that is more than enough for you all. And the 4th thing that can cause pulmonary hypertension in children is mitral stenosis. Okay, you all know that mitral stenosis can cause pulmonary hypertension due to the fact that blood is not passing from one side of the heart from one to the other, right? So therefore, pulmonary hypertension can be caused because the problem between the left side of the heart, there's a block. So therefore, blood is left move in the pulmonary circulation. Okay. So is our pan gile ituka. So therefore, what are the 4 things that we need to talk about? All right. Let me just tell you what are these: idiopathic pulmonary hypertension, Eisenmenger's, then chronic pulmonary thromboembolism, and mitral stenosis, right? Now, when this happens, if there is severe pulmonary hypertension, the chances of dying is what? About 20 to 40%. It is not so much, but so therefore, these conditions may be managed with different approaches. Termination might be offered, right? If it is mitral stenosis, of course, different kinds of valvotomies can be offered. The balloon valvotomy, where a balloon is put, expanded, and the mitral stenosis is relieved. You can do open or closed valvotomies, right? And sometimes even during pregnancy, even valvular replacements can be done if it is mitral stenosis. Okay. The rest of the things, it's very difficult to resolve. So therefore, terminations may be afforded. different kinds of medication can be continued. Usually sildenafil can be continued to reduce the pulmonary hypertension. Then intravenous prostacyclines can be used to reduce pulmonary hypertension, right? So those are the drugs that can be used. There are other drugs that are used like different types, but these are maybe found to be embryogenic, so they are not used now. So most of the time, commonly used two drugs are what? Sildenafil during pregnancy, right? And then prostacyclines, right? So, remember, the prognosis of all these things may not be very great, and they will definitely run into trouble somewhere. So they need cardiologist input, sometimes terminations, they need ICU care. So therefore, these are very complex, difficult cases in which you need to manage, right? Then the next thing which we have to remember, or we will talk about, is aortic dissections, right? Where there are dissection of the aortas. Now, they present, which are, as obstetricians, what you have to understand, they present with the late pregnancy, right? Where the pressures are higher. Right? Sorry, one moment. Okay, sorry. Right. So the aortic dissections, right? What you have to remember, children, they come with two main problems, right? Severe chest pain, right? Or interscapular pain, pain between the two scapulae, right? In that case, of course, you have to suspect this, and of course, you have to go for a proper diagnostic criteria. So echocardiograms, CTs, MRIs, all these will be necessary if you suspect that, and therefore you have to go for that, and then for the necessary interventions if necessary, right? In what patients are these common? These are common in the specific subgroup of patients, right? Anyone can have, but these are patients who are Marfan syndrome. Sometimes they can come with dissections, aortic dissections, right? Ehlers-Danlos syndrome, they can come. Turner syndrome, these are the patients who might have a higher risk for these aortic dissections, right? And then remember, in these patients, if you think they're at high risk, right? You can monitor these patients, especially by looking at the aortic root. And if the aortic root is dilated more than 4.5 centimeters, they have a higher risk of having this aortic dissection. So you have to keep in mind, yes, there's a possibility that this woman can have an aortic dissection at some point. So if the aortic root in these patients, if the aortic root dimensions are less than 4 centimeters, they can even go for a vaginal delivery. However, if it is less than more than 4.5 centimeters or more than 4 centimeters, then it is advised that we go for a elective cesarean section because they have a high, during vaginal delivery, due to the increase in pressure and everything, they can have an aortic dissection and they can die, right? So these are the general information that you need to understand about aortic dissections, right? Remember this subgroup of patients, children, Marfan's, Ehlers-Danlos, Turner syndrome, these are the patients which might have these complications. So in these patients, it is better to serial aortic root dimension, serial aortic root measurements, as well as serial follow-up to make sure that everything is all right. At least we can catch them early. If sometimes it's not, it happens so quickly and death might ensue, but sometimes we are able to manage these properly. You all understand? Right. Then let's talk about right, what it is. Okay, so that is one window. The next thing we need to talk about is about we spoke about mitral stenosis, right? So if there's a patient who is coming with mitral stenosis, it causes pulmonary hypertension, but in a way it is if these are the patients who have had balloon dilatation earlier, mitral valvotomies earlier, but still again may develop during pregnancy again. So these patients can undergo what? Closed valvotomies, open valvotomies, then what is this balloon balloon dilatations, right? And sometimes even during pregnancy, they can, if necessary, undergo replacements. But usually the non-invasive, not very invasive ones are practiced initially to sort it out until she delivers. Okay, so there is mitral stenosis. The next is what we have to consider is the ischemic heart disease or coronary problems, right? So for these, who are the patients who are at high risk? Who has had myocardial infarctions before? Who has had transient ischemic attacks before? Who has had the problems with the coronary arteries before? Who are the high risk ones? The ones who are obese, the ones who are having ischemic heart disease, the ones who are having different kinds of connective tissue disorders, the ones who are having hypercholesteremia, familial hypercholesteremia, right? These are the patients who are at a higher, ones who are older than 35, 36 years of age. These are the ones who can have ischemic heart disease. Now we are seeing patients who are younger and younger who might be having ischemic heart disease, and myocardial infarction is one of the top killers of pregnant patients among all diseases, right? So when a woman comes with severe chest pain, sometimes epigastric pain, right? It might radiate onto the back, it might radiate on the hands, right, arms. Then you have to suspect these patients of having a coronary problem. In which case the diagnosis remains the same. There's no difference. The troponin eyes, the troponin test, there's no difference in pregnancy. They can be used to diagnose ischemic heart disease, right? Or myocardial infarctions. Is that clear? And of course, the ECG changes are also very exaggerated and similar to a non-pregnant patient having an MI. Okay. But what is very important you have to understand is troponin can be used as the primary diagnostic tool for myocardial infarctions in pregnancy as well. Okay, you all understand? So it can be safely used because it does not change during pregnancy, right? So that is something that you have to understand. Okay. The next, we spoke about children aortic dissections, right? We spoke about mitral stenosis. We spoke about artificial heart valves. We spoke about yes. What else did we speak about?
Aortic dissections.
Aortic dissections. We spoke about pulmonary hypertension, right? Secondary to heart problems. And then the next thing we have to speak about is peripartum cardiomyopathy. Okay. What is peripartum cardiomyopathy? Is left ventricular dysfunction, right? Or heart failure, right? Secondary to global dilatation of the heart. Okay, so the whole heart dilates, right? All four chambers dilate. The reasons are unknown. So it's basically she goes into heart failure because the whole heart becomes enlarged and dilated, right? It's dilated cardiomyopathy. Okay, it happens towards the end of the pregnancy most of the time, and then it happens in the postpartum period. Okay, and if untreated, they can die. So it's a very, very difficult. So normally, if it resolves within 6 months, the prognosis is good, but sometimes it does not resolve. So they can have huge amount of problems, right? It is a diagnosis of exclusion because the reasons are unknown. So you have to check. The cardiologist will do that. They will exclude all the rest, the infective causes, this and that, everything, and then they'll say, okay, this is due to peripartum, due to pregnancy that this happened. Okay, so that is why it's called peripartum cardiomyopathy, right? So that is all you need to know about that. So it is it needs to be managed in the ICUs along with the cardiologists, the intensivists. So it's a big problem if it happens. But you need to be aware that if the woman comes with discomfort, dyspnea, features of heart failure, right? Then you, of course, you have to do an echocardiogram, and then it might be diagnosed. Then the diagnosis, you have to exclude other causes, then you arrive at a diagnosis of peripartum cardiomyopathy. Then hypertrophic this cardiopathy, right? That of course, usually it is congenital. So it's always there. They become pregnant, then you diagnose that. Usually the prognosis is okay. Hypertrophic cardiomyopathy, usually the pregnancy, so it's managed according to normal guidelines as managed when managing a hypertrophic cardiomyopathy. So most of the time the prognosis is all right. So, but the management is along the general guidelines that we use for any other heart disease in pregnancy, right? So those are the things. What are the other things? I spoke to about the arrhythmias, right? If the arrhythmias, most of them are supraventricular arrhythmias, and usually they can be beta blockers can be used, right? And of course, if these are not effective, then IV adenosine most of the time can sort out this supraventricular tachycardias, which are given when the patient has been admitted to a cardiac ICU. All right. So the other condition is in infective endocarditis. Right. Now, infective endocarditis for patients, just because the patient has a heart disease does not mean that we have to give them automatically antibiotic prophylaxis. However, any patients who are at a higher risk of having infective endocarditis, or patients who have had cardiac events before, right, like MIs or history of infective endocarditis, patients who have had valvular lesions, growths, right, all these patients during pregnancy requires antibiotic prophylaxis. What are the antibiotics we use? The recommendation is, children, because you may be asked this, is 2 grams of amoxicillin IV at the rupture of membranes or the commencement of labor, plus 120 milligrams of gentamicin IV if the kidney functions are normal. Okay. For patients who, and then 6 hours later, you give them 500 milligrams of amoxicillin orally, right? And then you continue that. If the patient is allergic to amoxicillin, you can give the patient vancomycin 1 gram IV or teicoplanin 400 milligrams IV. Those are the alternatives for amoxicillin allergy. Is that clear, children? Right? So those are the antibiotics which we use for pulmonary hypertension. Infective endocarditis. Right? So I think I have covered all the important sort of areas, the general overview of cardiac disease which you need to understand. So what we are going to do is now, you all understand now? So in a nutshell, if we summarize everything, we have gone through what? We have gone through the causes which are acquired and congenital. Okay. Then we have gone through the ECG changes during pregnancy. We have gone through the physiological changes during pregnancy. Okay. And we have incidence is, of course, very much less than 1% of all pregnant patients. Okay. Right. Then we have gone through the important prognostic factors for heart disease, which are 4. Remember, what functional class the woman is at the onset of the pregnancy, right? 1, 2, 3, or 4 New York Heart Association classification. Then the presence of pulmonary hypertension, the presence of cyanosis, and the 4th thing is how much this particular lesion is contributing to the hemodynamic stability, right? Whether it is causing hemodynamic problems or not. Okay, so these are the 4 important factors that you need to understand about the prognosis of these patients, right? The next, we have gone through different different kinds of problems that we meet, and we have discussed the general principles for the management of these problems. We have gone through mechanical heart valves, patients who come with that, and we have spoken about anticoagulation and the principles behind that. Second, we have spoken about pulmonary hypertension, the 4 problems that can cause. Remember, mitral stenosis, Eisenmenger's, then chronic thrombotic or disease, which can be caused by connective tissue disorders such as scleroderma or sickle cell crisis or sickle cell disease. Okay, and Eisenmenger. So those are the 4 things that and mitral stenosis. Those are the 4 things that can cause problem with mitral and what we normally do about this patient. Right. Then we have spoken about infective endocarditis and antibiotic prophylaxis and when it is necessary. Then we have spoken about arrhythmias and I have told you that it is mainly supraventricular tachycardias and beta blockers can be used. If necessary, we use adenosine IV, right? Then I have spoken to you about what? Pulmonary hypertension I spoke. What else did you speak about, children?
So peripartum cardiomyopathy.
Peripartum cardiomyopathy, which I spoke to you about. Then hypertrophic cardiomyopathy, which may not pose a huge problem actually because it's congenital and they are used to it, right? And what else? So those are the and aortic dissections, right? I told you mainly what to be on the lookout for. And then we also spoke about ischemic heart disease, right? Which the management is no different from the normal ischemic heart disease. Remember the diagnosis is troponin and what is the other one? Troponin and ECG changes. And of course, all the types of management as usual in IHD can be used with it. Stents can be placed, direct percutaneous thrombolytic agents can be put into the clot, right? I forgot to tell you that. So percutaneous thrombolysis is a very good option for pregnancy because it is minimally invasive, right? Then you can, your stent placement is possible, but stent placements can cause what it is, dissections, aortic dissections and problems, right? Valvular dissection. So you have to be very, very careful. So usually percutaneous thrombolysis is more accepted in pregnancy, right? So those are the topics which we covered, which is the general overview of heart disease. So the next 2-3 weeks, what we'll do is, right, I will take two sessions, I think. I will concentrate on 4 important problems in heart disease, right? Mitral stenosis, aortic problems, cardiomyopathy, we will go in depth, and then we will talk about, what did I say? Mitral stenosis, then aortic problems, cardiomyopathy, and ischemic heart disease. Those are the 4 things we will do. I will do 2 next week and 2 next week. So all of cardiac disease in pregnancy is covered. I will be concentrating on the obstetric cycle, children. What to do in the preconception, what to do in the first trimester, second trimester, third trimester, how delivery is managed, what special considerations, and how she's going to be followed up in the postpartum period, right? So I will go through these obstetric cycles for these 4 conditions. If possible, I will do it in 1. If not, I will do it in 2 classes. Okay. Right. Any questions? Sir, can you please repeat the prophylaxis regimes for infective endocarditis? Right. The prophylactic regimes are, normal regime is for infected amoxicillin 2 grams intravenous in combination with gentamicin 120 milligrams IV, and then 6 hours later 500 milligrams of oral amoxicillin is given. Okay. If a woman is allergic to amoxicillin, then either teicoplanin 400 milligrams IV can be used, or vancomycin 1 gram can be used. So that is a regime. Then significance, somebody says the signal mitral valve prolapse, nothing much. Mitral valve prolapse, most of, if almost everyone, a lot of people will have mitral valve prolapse. So usually the significance is not very much during pregnancy. Okay. Right. Okay. Then that is all. Any questions, children? it's a slightly complicated topic, but what I want you all to understand, children, is that you have to have first an overview. So then it's certainly because nobody is going to ask you very complicated questions on heart disease. But of course, if you have the overview, plus the 4 topics which I will do in the next subsequent classes, I think all of the heart disease is covered completely for you all, right? Okay. Okay.
Thank you, sir.
Okay then.
Thank you, sir.
Thank you, sir. Good night.
Thank you, sir.
Thank you, sir.